Welcome to Healing Hearts, empowering critical care providers. The information provided in this podcast is general in nature and is intended as a training tool for Children's Hospital and Medical Center personnel. This podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Complete information regarding the podcast, including its limitations on usage, is available under the episode description.
Welcome to Healing Hearts, empowering pediatric critical care providers, a podcast channel at Children's Hospital and Medical Center. My name is Siddharth Mahapatra, and I am a pediatric intensivist. Concluding our three-part shock series, we will now discuss the other shock states we had identified in Part 1, including cardiogenic shock, neurogenic shock, anaphylactic shock, toxin-mediated shock, hypovolemic shock, and obstructive shock. The objectives of this podcast are to discuss types of shock other than septic and to undertake a detailed review of cardiogenic shock. Let's get started with cardiogenic shock. Cardiogenic shock is defined as an acute state of circulatory failure due to impairment of myocardial contractility. It represents 5% of pediatric emergencies and 10% of mortality in hospitalized children. Mortality is directly related to the underlying disease. In 5% of the cases, it's due to congenital heart disease. In 10% of the cases, acquired heart disease. And in about 25% of the cases, cardiomyopathies, and another 25% of the cases because of rhythm disorders. And finally, there's a miscellaneous category as well. Causes can include cardiomyopathy, myocarditis, arrhythmia, congenital heart disease, postoperative period after cardiac surgery, endocarditis, rheumatic fever, severe Kawasaki disease, stress cardiomyopathy, valve cord rupture, and or drug or toxic substance intoxication. To understand cardiogenic shock states, it might be helpful to think about whether the child has congestion at rest or hypoperfusion at rest. Congestive signs would include orthopnea, hepatomegaly, edema, crackles in their lungs. Signs of hypoperfusion would include altered mental status and confusion, delayed cap refill, cold, clammy extremities, tachycardia, renal failure. And so a child can have one or both of these at rest. And you can then define whether a child has systolic dysfunction or diastolic dysfunction. A child with systolic dysfunction would have hypoperfusion at rest. A child with diastolic dysfunction would have congestion at rest. And so a child that has simple diastolic dysfunction due to high left ventricular filling pressures would have just congestion at rest. A child with systolic dysfunction would have reduced myocardial contractility and thus hypoperfusion at rest. And a child that had combined systolic and diastolic dysfunction would have both reduced myocardial contractility and increased left ventricular filling pressures. Thus, they would have both hypoperfusion and congestion at rest. This might help you in how to manage the patient if you can diagnose whether the problem is systolic or diastolic dysfunction. The investigation for cardiogenic shock starts with a very thorough physical examination, which might reveal ashen skin, mottled extremities, cool to touch because of systolic dysfunction and lack of cardiac output, crackles in the lungs, jugular venous distension for your larger patients, additional heart sounds like an S3 or an S4, narrowed pulse pressure, or other signs of hypoperfusion like oliguria and altered mental status, and a depressed liver edge. Imaging modalities can help. This includes an EKG that can show you signs of arrhythmia, a chest X-ray that can show you aortic dissection or pneumomediastinum or a pneumothorax, and most importantly, an echo and a cardiology and intensive care consultation. The management of cardiogenic shock requires multidisciplinary ICU-level care. In fact, fluid resuscitation may be contraindicated in a child that has diastolic dysfunction that can worsen their dysfunction, lead to worsening crackles and worsening lung examination and hypoxia. In fact, for patients in heart failure from cardiogenic shock due to diastolic dysfunction, they may actually require diuretics to address the fluid overload and the ventricular dysfunction. Common vasoactives that are used in cardiogenic shock differ from septic shock. For example, milrinone, an agent that helps with diastolic dysfunction and RV failure, is often used to alleviate this diastolic dysfunction. It also has inotropic properties and can also be a vasodilator. It may also help address pulmonary hypertension. Epinephrine and or dopamine can be used to maintain cardiac output in patients with systolic failure. Most often, patients with cardiogenic shock require a combination of the two in order to help them reestablish tissue perfusion. Next, let's discuss neurogenic shock. Recall that neurogenic shock is a type of dissociative shock state. It occurs when there's spinal cord injury above the 6th thoracic vertebrae that leads to a detriment on your sympathetic chain. Thus, there's interruption of sympathetic outflow and increased vagal tone. The hallmark vital signs in neurogenic shock include hypotension because of decreased systemic vascular resistance and bradycardia because of elevated vagal tone. Hence, fluids will not help a patient with neurogenic shock, and once diagnosed, the patient's first-line treatment should be vasoactives like epinephrine, which helps to reestablish SVR as well as elevate heart rate to meet the perfusion needs of the patient. Next is anaphylactic shock, which is another type of dissociative shock, which takes place through an IgE-mediated response, where allergens specific for IgE bind to and cross-link IgE molecules on mast cells and basophils. This leads to an activation and degranulation of these mast cells and basophils, leading to a release of histamine, tryptase, leukotrienes, and prostaglandins, which lead to that dissociative state and loss of vagal tone. Histamine can bind to H1 and H2 receptors. The histamine 1 receptors lead to skin findings, such as hives or respiratory distress. The H1 and H2 together can lead to hypotension, headache, flushing. Thus, these are the most important physical signs to look for in a patient with anaphylactic shock. Remember that anaphylactic shock can actually be biphasic. It can, in fact, last up to 24 hours, which is why sometimes patients with anaphylactic shock may be kept in the hospital for further management and monitoring. The first-line treatment for anaphylactic shock is epinephrine. You can also give steroids and histamine blockers, but epinephrine really quells the shock at its source. Next is toxin-mediated shock, another type of dissociative shock state. Common toxins that are found to cause toxin-mediated shock include those that cause toxic shock syndrome, such as Staph aureus and group-based strep endotoxins. These lead to endothelial damage that then leads to loss of vascular tone, hypotension, and multisystem involvement into shock. One of the classic signs includes diffuse or localized pain that's abrupt in onset, severe, with physical findings of soft tissue infection. Treatment, aside from treating shock, is a bactericidal agent like vancomycin and a bacteriostatic agent like clindamycin that reduces toxin production. It's so very important to have a good history to diagnose toxic shock syndrome in order to institute the right treatment. Other chemicals and toxins, such as cyanide and carbon monoxide, can also lead to toxin-mediated shock. In fact, cyanide leads to a decoupling of the electron transport chain, preventing aerobic respiration, and thus leading simply to anaerobic respiration and lactic acidosis and ensuing hypoxia. Carbon monoxide dramatically reduces hemoglobin's affinity for oxygen, and thus leads to a reduction in the carrying capacity of oxygen by blood, and thus leads to hypoxia by a reduced delivery of oxygen at the tissue level. Again, knowing the underlying causes of these toxin-mediated shock can really help you treat these patients better. And finally, hypovolemic shock can either be hemorrhagic or non-hemorrhagic. Hypovolemic shock can occur due to burns, Stevens-Johnson syndrome, heat stroke, can occur due to GI losses, such as emesis, diarrhea, ostomy losses, or can be due to overzealous use of diuretics. Remember that hemorrhagic causes of hypovolemic shock can take place, and they occur because of acute GI bleed. or acute liver failure, or DIC that can take place in septic shock. So shock states can really come together, and so it's very important to try and understand the different types of shock states and to diagnose each of them so you can manage them appropriately. And last but not least is obstructive shock. Two types of obstructive shocks include one caused by elevated pulmonary vascular resistance that leads to right ventricular failure due to acute rise in afterload. This could be due to pulmonary hypertension or pulmonary embolism. Or it can be mechanical, which compromises preload and venous return, and this can be due to cardiac tamponade, tension pneumothorax, or restrictive cardiomyopathy. So the take-home points of this podcast are: first, cardiogenic shock is characterized by hypotension due to low cardiac index in the setting of narrowed pulse pressure and signs of shock despite adequate fluid status. Remember that fluid boluses are contraindicated. In fact, diuretic therapy, milrinone, and epinephrine are the mainstay of therapy. Neurogenic shock, remember, is characterized by low heart rate and low blood pressure due to lack of sympathetic tone and is treated by epinephrine as a first-line agent. Anaphylactic shock is caused by an IgE-mediated response and is treated by epinephrine as a first-line agent, but may be supported by steroids and histamine blockers. And finally, toxin-mediated shocks, such as toxic shock syndrome, is treated by addressing both the bacterial etiology and toxin production. Thank you very much for joining me on this 3-part shock series.
For more information about Children's Hospital and Medical Center, visit children'somaha.org. Thanks for listening to Healing Hearts, Empowering Critical Care Providers.